Okay, the changer and the change, the therapist's transition in working with issues of transgender in relational psychoanalytic psychotherapy. This presentation has come about as a result of some clinical experiences I've had as a psychoanalytic therapist committed to a relational perspective in working with clients who were contemplating or who were undergoing gender reassignment. It's come out of some of the challenges of that work to my own conceptions of gender, what it is and what it means. This isn't a clinical paper though. The usual stance of a clinical paper, focusing on the client's material and telling a client-focused narrative, can tend to render the client the object of the therapist's clinical gaze. What I would rather try to consider is the impact of the transsexual client, and by extension the impact of current transgender discourses, upon the therapist, in an attempt to sketch some of the changes that may need to take place within the clinician's transition, if you like, in order to be able to work non-oppressively with clients who are contemplating or undertaking sex change procedures. What happens to the therapist when psychoanalytic and transgender discourses meet? In working relationally with our clients, we recognise that, as Lewis Aron formulated it, the patient-analyst relationship is continually established and re-established through ongoing mutual influence, in which both patient and analyst systematically affect and are affected by each other. A communication process is established between patient and analyst in which influence flows in both directions. This two-person therapeutic approach acknowledges in some sense the potential plasticity of each of our subjectivities and the possibility that both participants may be changed by their reciprocal dialogue, us as well as them. Jessica Benjamin spells out what she calls the risk of being transformed in an engagement with others whose horizons are different. And I quote, "Challenging identity always threatens to be a reciprocal process, and in psychoanalysis our subject can always surprise us, turn the tables on us, however painful that may be." This is challenging territory for therapists in relation to transsexuality as in relation to so many other stigmatised subjectivities that psychoanalysis has sought to explain. We may need to engage with the discomfort and disorientation that transsexuality can arouse in non-transgendered therapists, even queer ones. And perhaps we feel we should be beyond that by now. But my own experiences and my conversations with other colleagues, queer and otherwise, and some therapists' published accounts of their clinical experiences with trans clients tell me that this is not likely to be the case. We are still in transition. I'm going to use there's been references to English literature, so I'm going to use some references to a piece of English literature that is probably familiar to most people. In another moment, Alice was through the glass and had jumped lightly down into the looking-glass room. Then she began looking about and noticed that what could be seen from the old room was quite common and uninteresting, but that all the rest was as different as possible. To transition is to pass from one state into another. It means to go through, to go across, to go beyond. For transsexual persons, transition denotes the social, emotional and physical journey from life on one side of the gender binary to life on the other. But as psychoanalytic therapists engaging with issues of transgender, what is it that we are going through? Are we crossing a line? And what is it we're going beyond? Beyond our comprehension, beyond psychoanalysis, beyond ourselves? If the therapist goes through the looking glass, does psychoanalysis go out of the window? Through the lens of binary gender, psychoanalysts have often interpreted trans identities as delusional or psychotic, and trans bodies as false. Binary thinking inevitably tends to reproduce its anxious, oppositional dynamic in the transference-countertransference matrix. And so it's axiomatic of many classically oriented psychoanalytic accounts that the analyst must resist recruitment into the patient's delusion. Thus, Agnes Oppenheimer, in the International Journal of Psychoanalysis, this is 1991, criticises Robert Stoller's wish. Stoller did an enormous amount of work with transsexual patients, and his book, The Transsexual Experiment, people may be familiar with. She criticises Robert Stoller's wish to legitimise the subjective experience of his transsexual patients as being, quote, extreme validation, quote, beyond the necessary degree of recognition, tantamount to a sharing of his patients' absolute need for confirmation of their decision to change sex. She persists in referring to her subjectively female transsexual patients as he, although years have passed since their reassignments. Such accounts firmly maintain the analyst as the objective subject who sees what's really going on in the other, and the patient as merely subjective object, opaque to themselves and thus pathologically deluded. They can't both be sane, and the analyst certainly isn't going to join the crazies. Lesbian and gay therapists may wince in recognition of these dynamics, but can we also fall prey to our own version of them? Can our own conscious and unconscious investments in stable, binary categories of gender and sexuality put a spin on how we interpret the narratives of our transgendered clients as gay and transgendered discourses collide? Arlene Lev is a therapist working with sexual minorities in Albany, New York. She describes her response to her first transgendered client, who had been living successfully as a lesbian since the age of 15, and who was integrated socially and politically into her lesbian community. She had a gay supportive family, and she had a long-term girlfriend. Right. This is the client speaking to the therapist. She says, "The client, Mel, looked at me sheepishly and said, 'I'm really not a lesbian. I think I'm a guy.' My first thought was that this was a case of internalised homophobia, albeit an unusual one. When Mel said, 'I don't feel as if I'm a lesbian,' it sounded like the kind of internalised self-hatred I'd heard numerous times from women and men, young and old, struggling to make sense of their homosexuality in a queer-hating world. From my perspective as lesbian affirmative therapist, Mel's story is a familiar lesbian narrative with a somewhat disappointing ending. Something was very wrong." Nor is it only classical psychoanalysts who attempted to label transgendered subjectivity as delusional when the erotic imagination transcends the limits of apparent physical reality. Lev describes meeting with Mel and her girlfriend Rose as a couple. "When I asked Rose what she thought of Mel saying she was not a lesbian, she said pointedly, 'She's not, and neither am I.' Rose explained that she had always felt identified as heterosexual, and that this sense of self had not changed since she fell in love with Mel. 'I see Mel as a guy,' she said." As a gay-sensitive therapist, it would almost appear that Rose was suffering from an almost delusional internalised homophobia by colluding with her lover's perspective. I just want to say that Arlene Lev has written a wonderful article on her own personal transition in dealing with these issues. So what she's describing here are her initial reactions, and she then goes on to say very interesting things about how she changed her views. Lev notes that gay and lesbian clinicians may enter the dialogue with transgender discourses with a conflicted legacy from our own culture. owning our transgressive gender presentations on the one hand, whilst denying their links to queer sexual identity on the other. She states, "The place where gender and sexual identity meet has yet to be addressed within our clinical discourse." I think I might just give you a couple of minutes to kind of get to grips with that photo. For those who are interested, the middle photograph is the work of Kevin Aucoin, who's a Hollywood makeup artist, and the two people on either side I think should be very familiar. Obviously the one on the left is James Dean, and the one on the right is Gwyneth Paltrow, and the person in the middle is Gwyneth Paltrow as James Dean. Rebels without a cause. Psychoanalytic accounts of transsexual subjectivities, as with homosexual subjectivities previously, are fraught with attempts, sometimes verging on the frantic, to find one key which will unlock the etiology of transsexuality. Separation anxiety, blissful fusion with mothers, emotionally absent fathers, and psychotic denial of reality all feature in explanations of atypical gender identity in boys. Female to male transsexuality is variously attributed to parental devaluation of girls, encouragement to play masculine roles in relation to weak, emotionally withholding mothers, and internalised homophobia, as we've just heard. The usual suspects appear: too much mother, too little father, not enough Oedipus. We've heard it all before. And maybe in relation to transsexuals, we've even heard ourselves saying it. The problem with these accounts is their universalising, pathologising standpoint. What transsexual lesbian Sandy Stone has said in relation to Janice Raymond's feminist polemic against the transsexual empire, it's a book that people may be familiar with, it's the first book I ever read about transsexuality, applies just as well to the accounts that we've inherited from psychoanalysis. This from The Empire Strikes Back. But still, there are no subjects in these discourses, only homogenised, totalised objects, fractally replicating earlier histories of minority discourses in the large. So when I speak the forgotten word, it will perhaps wake memories of other debates. The word is some. We should hardly be surprised if the commandeering of individuals' life narratives for the purposes of universalising and pathologising their subjectivities leads some transsexual persons, as it has other sexual minorities, to embrace biological accounts that locate the origins of gender in the structures of the brain. This is the view of gay biologist Simon LeVay, who states that, quote, "For most core transsexuals, there simply is no history of traumatising experience, relationships, or illnesses that could possibly explain such a radical departure from conventionality. And transsexuals do not appear to be mentally ill. I feel confident that biological markers for transsexuality will eventually be identified." The sociologist Holly DeVore, now Aaron DeVore, has probably done more than anyone to document autobiographical narratives of transsexual lives. Participants in her major study of FTM transsexuals identify a variety of relational histories that may have contributed to the transsexual choices they've made, including the creation of protective male alters in dissociative responses to child sexual abuse. Bill just about covers all the bases when he puts it this way: "I don't know the reasons in my case, although I certainly have thought about it. Did I want to be special, the only boy among 5 children? Did I identify with my persecutor, my father? Did I perceive women as weak and ineffective victims of male aggression and domination and identify with my father in order to survive? Did I simply hate the thought of growing up and see this as a means of escape from the responsibilities and craziness of the adult world? Did I see myself as my mother's rescuer and need to be male to fill that role? Perhaps the answer to these and others is yes, with a little of the old biological predis thrown in. Or perhaps none of these questions fits the bill. I will never know unless God indeed provides answers someday. DeVore concludes that ultimately the causes of transsexualism in individual persons' lives are beside the point. Most people who would ask to understand the sources of transsexualism do so in order to seek either the prevention or the cure of transsexualism. A far superior use of our energies as a society would be to apply them to creating an environment in which persons may live in whatever modes of gender or sex expression they wish. Sorry, I am going to run over, so please bear with me. The question for clinicians with a commitment to a collaborative psychoanalytic inquiry into subjectivity, undertaken together by therapist and client, is whether and how we can transcend the polarities of pathologizing psychohistories of gender on the one hand, and the indifference to unconscious meanings of naturalizing biological accounts on the other. We need a psychoanalytic account of transsexual subjectivity that, as Patricia Elliott has framed it, can raise questions about processes of embodiment without normalizing or pathologizing, and that aims to provide the freedom needed to consider alternatives. I'm going to say something now about the binary between surgery and insight. Never cut what you can untie. In our psychoanalytic paradigm, we tend to cultivate the binary split between mind and body, with the mind a superior pole. As Susie Orbach has pointed out in her work on the relational body, the psychoanalytic wing of our profession over-evaluates mind and thinking as a kind of moral superego to feelings and bodies, treating the body as a dustbin to the mind. The concrete language of the body is seen as simply a developmental way station en route to the symbolic language of the mind. And in the case of transsexuality, bodily transformation by surgery is regarded as an inferior route to the desired destination of mind-body congruence. It falls short of the analytic ideal of transformation through insight. Thus, for Agnes Oppenheimer, quote, the putting into effect of their intention to change sex limits the possibilities of psychical development. At the other extreme, some transsexual accounts can tend to privilege the material truth of the body, focusing on biological and surgical narratives, but denying the experience of physical embodiment, its psychic and relational origin. This, for example, is how Jack, a participant in Holly DeVore's study, puts it. I certainly didn't ask for this. I didn't learn it anyplace. You know, some things are learned, and there are some things that are just born in you. Those things that are born in you, I don't think you can change them. This is one of them. It's born there, and you can't get rid of it. Robert Stoller, writing in 1975, as women's and gay liberation gathered momentum in the aftermath of Stonewall, acknowledged some of the anxieties that transsexuality still poses for many psychoanalytic therapists, among which it raises intensely felt ethical questions regarding the propriety of using hormones and surgery to change anatomy, for this is the only condition in which genital and therefore reproductive normality is destroyed for psychological reasons alone. And 25 years later, in advocating caution to therapists working with gender variance, Karen Moroder warns us that, quote, we know precious little about how our sexual identities, sexual preferences and gender identities are formed. When our patients ask us for explanations, we are truly at a loss much of the time to provide them with any certainty. How much do we encourage our patients to take any action in their lives, especially if it includes major surgeries? How much do we accept about who we are and how much we can change, both internally and externally? And what about potential consequences? How do we determine what transformations are possible versus what must be grieved as unattainable? Perhaps it's the anxieties raised by the therapist's sense of responsibility for their patient that leads us to pose these questions in terms of how much we, the therapists, encourage and determine our clients' choices of action, rather than how we might enable our clients to determine their own possibilities. Remembering Freud's dictum, and I think Jack Drescher referred to a similar idea last night, Patricia Elliott reminds us that, a quote from Freud from The Ego and the Id, analysis does not set out to make pathological reactions impossible, but to give the patient's ego freedom to decide one way or the other. As analytic therapists, these complex anxieties can lead us to become caught up in a gatekeeper countertransference, even though we may have no direct input into questions about access to treatment procedures. If this is the case, our tendency may be to see a client's choice of surgical intervention as a mark of our therapeutic failure to prevent an act of self-mutilation by the client, whereas the client is more likely to see their bodily transformation as an act of self-creation, enabling them finally to claim their subjectivity in a disconfirming world. This is a photograph by the transsexual photographer Lauren Cameron. It's a photograph of himself. Sorry, it's come up rather small, but he's injecting himself with testosterone in that photograph. And I'm quoting from him. Taking testosterone as hormone therapy and developing a bodybuilding regimen, I ever so slowly and painfully began to reinvent myself. I photographed myself and sent amateur snapshots to friends and family in order to show them how happy I was. I wanted them to get used to the idea of my body being different. If they could see my new beard and chest, sans breasts, perhaps it would be easier for them to accept my new identity. You know, so they would stop calling me she. I was excited too, much like when I discovered my sexuality as a teenager. Only this time I refused to feel any shame. I was creating a beautiful new body image, and I was proud of it. Acknowledging the creative and empowering aspects of body reconstruction doesn't imply that we dissociate or deny the risk, pain, and anxiety of surgical intervention, or the likelihood that significant relational issues will remain to be explored afterwards. With transsexual clients, as with any others, we need to be able to hold the binary tension between gain and loss inherent in any creative transformation, however painful. I'm coming up to the end, but... Okay, this is Alice and the White Queen. Now I'll give you something to believe. I'm just 101 5 months and a day. Can't believe that, said Alice. Can't you? Said the Queen in a pitying tone. Try again. Draw a long breath and shut your eyes. Alice laughed. There's no use trying, she said. One can't believe impossible things. I dare say you haven't had much practice, said the Queen. When I was your age, I always did it for half an hour a day. Why, sometimes I've believed as many as 6 impossible things before breakfast. We're living through a long historical moment of transition between paradigms. According to Virginia Goldner, feminism and the postmodern turn have vaporized the common sense materiality of gender and sexuality, both in theory and for many as lived experience. Old and new gender discourses are in competition with each other. Even those of us who are questioning old organizations of gender struggle to maintain our grasp on the new. We may experience ourselves continually shifting from one paradigm to the other as we pass through the looking glass and back again. We may scramble to maintain a foothold in both worlds, in the old discourse of binary gender that allows us to inhabit our everyday identities, and in the new discourses of gender as a performative construct, a necessary fiction, a false truth, that is, as Adrian Harris puts it, at this historical moment, both necessary and inadequate. Six impossible things about gender. In making our own transition to new ways of understanding gender and transgender, we therapists may need to practice believing impossible things. In that spirit, I offer here 6 impossible things to practice believing about gender that I've found useful lately. You can try them in the comfort of your own consulting room. 1. All identities, including gender identities, are fictions. 2. It is our belief in these fictions that makes us feel real. 3. Whether we feel ourselves to be men or women depends upon our psychic reality. Psychic reality is physical reality. 4. There is no difference between a gender and a transgender. Both are equally real and equally fictitious. 5. What determines whether a relationship is straight or gay is not the sexes of the people involved, but the relational paradigms in play. 6. Thus, two female-bodied lovers, either of whom may or may not intend to seek any bodily reassignment, could be involved in a heterosexual, lesbian, or gay male relationship, or all three, or maybe something different. The process of rethinking our core beliefs about gender, or at least entertaining a new paradigm, can be experienced as profoundly disrupting of some of our most deeply held convictions about the aims of psychoanalysis, about our sexual politics, and about ourselves. Kate Bornstein, transgender activist and self-styled gender outlaw, who, having transitioned from male to female, now no longer defines her gender, quotes Murray Davis: "Anything that undermines confidence in the scheme of classification on which people base their lives sickens them, as though the very ground on which they stood precipitously dropped away. The vertigo produced by the loss of cognitive orientation is similar to that produced by the loss of physical orientation, a mental mal de mer, occasioned by the sudden shipwreck of cognitive orientation which casts one adrift in a world without structure." The challenge to us as psychotherapists who are heir to the analytic tradition is whether we are prepared to listen to those who have been living on the other side of the looking glass and try to believe in the impossible things they can see from there. If we can risk the cognitive and emotional disorientation and disruption to our own identities that this may entail, and as Immanuel Gent would have it, surrender ourselves to the impact of the other, then we might just inherit the most precious legacy that psychoanalysis has to hand on: the truly intersubjective encounter.